I am talking on National Swab Transplant Program to achieve self-sufficiency, challenges and solution. Less than 10% of patients with end-stage organ failure have access to organ transplantation. India is number 1 in the world for living donor transplant, and 85% transplants are from living donation. So mostly 25 to 35% living donors, they are rejected either because of ABO and HLA incompatibility. In our single center at Kidney Institute Ahmedabad, every year we do around 400 kidney transplant. So we maintain a single center registry of swab and we can easily provide them solution with the kidney exchange. In our single center, we have shown that access to living donor kidney transplant increased by 25%. So 1 out of 4 living donor kidney transplant in our institute is a swab transplant because of team efforts, software allocation, government support. So if this model is replicated in the multi-center program and national program, definitely we can increase access to living donor kidney transplant. So this is largest cohort study reported on liver and kidney swab in Lancet Asia. This is data of more than 2000 patients from 72 centers. All these centers have reported different challenges for proceedings with the swab transplant. Basically, swab is bureaucratically complex and medically simple. So when we want to envision for the national swab transplant program, we need operational guidelines on common challenges and common solution that I am going to present in next few minutes. The left panel is showing access to the living donor kidney transplant. The dark green shade shows living donor kidney transplant activity and red color shows there is no living donor kidney transplant activity, especially in the northeast. So swab is proportional to the living donor kidney transplant activity. Gujarat is leading in India for swab transplant, and our single center has done 25% of swab which are reported from the national cohort study. So what is need of national swab transplant program? In single center, we have increased access to swab by 25%. So in the national program, definitely this percentage will increase to 25 to 35%, because when donor pool will increase, the quality of matching and quantity of matching increases. Then what is biggest advantage of the multi-center and national program? More surgical team is needed to carry out simultaneous transplant surgery in the single center program. That problem will be overcome in the multi-center and national program. Then legal permission for multi-center swab. Yes, there is no prohibition for the multi-center swab program, and it should be explicitly addressed in the Organ Act. So Mumbai and Kerala, they have done more than 150 multi-center swab program as per permission from the appropriate health authority. Donor recipient relationship in the swab. Only near related donors, they are allowed to participate in the swab, and we suggest that other than near related donors should also be allowed, because they are given permission for other ABOI transplant as well. Then whether interstate matching is allowed or not. So in our single center, we have done 625 swab transplant, and almost 50% of our pairs, they are from different states. So interstate swab is legally permissible under THOA, and it should be encouraged to increase quality of matching and quantity of matching. Then which committee should give permission for the multi-center swab? Hospital, district or state in which transplant take place, that authorization committee should give permission for the multi-center swab, and patient should not ask that take permission from all the states from which they are participating. Then different states are asking different document checklist for the swab transplant. So NOTO has issued letter to all the states and health authority, one nation, one document checklist as per Transplant Human Organ Act. This letter is available on the NOTO website and circulated to all the stakeholders. Then timing for the swab transplant. So the first visit for renal replacement counseling, that should be the ideal timing for the counseling of all the available options: swab, ABOI, deceased donor transplant, dialysis therapy, so that patient can take informed decision. So early counseling is very key important, and so that he can arrange all the necessary documents required for the legal permission. Whether complex living kidney donor participate in swab. Recipient willing to accept complex living kidney donor should be clearly documented and recorded in the swab registry to ensure transparency and support informed decision making. As far as possible, exchange of kidney with similar quality is always encouraged. Then what is about the participation of the compatible pair, basically a spousal donor. So inclusion of such pair in swab, if done, must be voluntary and fully informed consent must be obtained. Pair must understand that participation may not guarantee access to a better donor. Any benefit conferred to such pair must be transparently documented. Their participation must be time bound, and clear timeline should be discussed at registration to ensure unnecessary delay in transplant. Then variation in donor recipient fitness criteria. So all the center come to one consensus and they should follow one guideline. Maybe we can say guideline they are defined by the KDIGO, or we can make a consensus guideline which is acceptable to all the participating center. Frequency of donor recipient fitness. So donor recipient fitness should be confirmed at the time of registration, and it should be reconfirmed at the time of offer of the match and before sending documents for legal permission. So as to avoid cycle collapse and chain collapse because of medical issues. Then immunologic workup. In our center we do robust immunological assessment with the help of lymphocyte cross match, flow cross match and donor specific antibody to avoid unequal outcome because of immune injury. So all the centers should make a consensus guideline which should be acceptable to the national swab transplant program. Then enrollment of the pair. We recommend that NOTO should establish a one window clearance system for registration, allocation and facilitating legal permission. So this will take care of all the logistics issue in the swab transplant. Consent in the swab. All donor and recipient must be fully informed about risk, benefit and logistics with written consent obtained in donor recipient native language. So they are entirely aware about the entire process. Information to be documented at the time of registration. All legal document medical report must be submitted, and informed consent for data sharing should be taken from both donor and recipient to ensure smooth coordination between different centers. Then waiting time. A large swab pool minimize pair spend waiting time. So at the time of registration, each patient and donor should be given information about the expected waiting time, so that he can take informed decision whether he want to go with the swab or he want to proceed with the ABOI. Additionally, there should be yearly counseling about all other available options if swab is not feasible. Then manual allocation and software allocation. So manual allocation, there could be a man-made error. In case of unequal outcome, this error could be contributed to manual allocation. So we always recommend use any software which you feel is available with you. The software allocation is always better than manual allocation, and this is specially required for difficult to match patient, for highly sensitized patient, for making a long cycle. With the manual allocation, we can do only two-way exchange for AB incompatible pair, but software is mandatory for allocation of highly sensitized patient. Then what should be the optimal frequency of match run? So to conduct match run every 4 to 6 weeks, balancing clinical urgency, logistic capacity and registry size. Flexibility should be built in to allow an ad hoc run in exceptional cases and special requests from pair, particularly for sensitized and urgent recipient. In our center, we do software match run when new patient is added to the pool, so patient need not to wait for a long time. Donor recipient age mismatch. It should be minimized when possible, particularly for young recipients to maximize survival. While not an exclusion criteria, age difference more than 20 years should trigger additional clinical review and shared decision making between transplant team and patient. So donor recipient age mismatch should not be limiting factor for hard to match patients. Donor age mismatch. Effort should be made to match donor of each pair as closely as possible. For hard to match pairs, donor age difference doesn't matter. Then multi-center versus single center program. The quality of matching and quantity of matching is always better in a multi-center program, although logistics are simple in the single center program. So we encourage a multi-center program rather than single center program. Short versus long cycle. The logistics are very simple in two-way exchanges, and the optimum chain length from our experience and international evidence is 3. So if we want to do a long cycle or long chain, this increase the logistics and other problem. So we should try to keep the simple short, and we do long cycle when it increase transplant for difficult to match patients like O group patients and sensitized patients. Non-anonymous versus anonymous allocation. In India and Asia, all the pairs are allowed to meet each other in the swab, in contrast to the practice from Western world where anonymous allocation is followed. So we believe that non-anonymous allocation increases trust, transparency between the transplant professionals, administration, patients and donor. So, and participation in non-anonymous allocation should be voluntary, and no individual should be pressurized to reveal his or her identity. Donor travel versus kidney transport. So 80% of the transplant services in India is in private sector, less than 20% is in the government center. When there is an exchange between public and private hospitals, we believe that kidney transport will be a better solution as compared to the donor travel. But however, the participating transplant center should decide which policy is more useful to them, and donor should decide whether he want to proceed for donor travel versus kidney transport. So both are feasible. Then for the public private swab, the kidney transport is much easy, and we already have a NOTO transport SOP for transport of organ that can be implemented in case of kidney transport policy. Unequal outcome for the payers. So we always give proper counseling to the payers before allocation that unequal outcome is possible because of patient related conditions, comorbid conditions in the patients. We try to prevent unequal outcome because of donor related factor. Despite doing all efforts, there is a chance that up to 10% there is a acute rejection. So if we do proper counseling, we avoid these concerns because of unequal outcome. For example, if one patient is having diabetes or heart disease and he get infectious complications after transplant, we always counsel the pair that these complications are possible, but this unequal outcome is because of comorbid conditions in the patient and not because of the swab transplant. So proper counseling is very important. To summarize, legal cost effective swab increases living donor kidney transplant by 25 to 35%. Because of the logistic challenges, we recommend NOTO for one nation, one portal for registration, allocation and legal permission. User-friendly software for allocation will increase transplant rate for difficult to match patient, incentives for promoting multi-center swab, and there should be mandatory swab counseling at the time of deceased donor registration so that patient can take informed decision if he if he is given information about all options about swab, in fact ABI also. Donor first policy should be implemented to decide about donor travel versus kidney transport, and living donor advocate and swab patient ambassadors can increase information to the patients about the swab transplant. And there is need to reform the Organ Act so that to allow other than near related donor for the swab transplant. Thank you for your attention.